Good morning. Good morning and welcome to Medical Grand Rounds. Just to give some people some preparation, we have 2 more weeks after today in our spring series, and then we will be taking July and August off for the summer. So next week we'll be hearing from Dr. Sean Sullivan. He's the Dean of the School of Pharmacy at the University of Washington, and will be here as part of our High Value Care series, discussing the high cost of prescription medications and what to do about it. Yeah. Stay tuned. I think it's all going to get solved next week. Come, tell your friends. Today I'm delighted to introduce Dr. Doug Koekkoek, who serves in the combined role of Chief Executive of Providence Medical Group and Clinical Services for Providence Health and Services in Oregon. I know he's a familiar face to many of us here. Doug earned his medical degree from OHSU and then completed his internal medicine residency and also served as chief resident at Providence Portland Medical Center. Dr. Koekkoek began his career as a primary care physician, where he served as clinic medical director before transitioning to hospitalist medicine. He has been truly integral in developing our hospitalist program across Oregon and continues to serve in a clinical role. He's a true advocate for patients as well as providers and has served in multiple leadership positions, including chair of the Oregon Regional Medical Executive Committee. In his current executive role, he provides oversight and guidance to regional nursing, pharmacy, home services, graduate medical education programs, and the Providence Medical Group. He's also intimately involved with the Community Health Division and evolving strategies in population health management, and we're very eager to hear his thoughts on Providence response to change today.
Thank you, Laura. I'm not used to such a lengthy introduction, especially amongst my friends and colleagues, but I'm thrilled you're all here. I hope that we can make this interactive and interesting for you today. The fact that you're all here on this beautiful spring morning to hear about healthcare economics and health system strategy is somewhat baffling to me, but I promise to make it worth your while. So the title of the Grand Rounds, Back to the Future, a little bit of an odd title. Full transparency, my favorite movie for many years, Back to the Future, and for house staff, it was a movie before it was the ride at Universal Studios. You guys probably don't remember that, but I chose this title because it seems like many of the strategies that we're going to talk about today and that you hear about in the lay literature about healthcare and what healthcare is doing seem like, well, I've heard that before. And so in many respects, what's new is, or what was old is now new again. Because we're talking again about capitation, and we're talking about clinical networks and IPAs and their influence on healthcare, physician employment. And all of these things were things that were popular back in the 90s. So I see a few folks in the audience who share gray hair like I do, so you'll remember some of this. But I guess what I'd ask of you as we go through the talk is sort of listen to what's different this time around and why we might be successful with some of these strategies compared to what we did in the past. Oh yeah, hospital mergers, I forgot about that. Well, let's talk a little bit about that too. So my goals over the next hour to talk a little bit first about market forces in healthcare, to talk about Oregon's population health strategy and what that is. I then want to go through some trends and some of the changes in the healthcare delivery models. And then lastly, I'll give you a glimpse of some of our system leadership's strategies and see if those make sense. And hopefully we'll have time for some question and answer as well. But let's start with market forces influencing healthcare. There's 4 things I'd like to talk about. First is the weakening of the Affordable Care Act, the growth of government-sponsored healthcare, the declining ability to cost shift losses onto commercial payers, and finally our ability, or rather inability, to bend the cost curve. Let's start with the Affordable Care Act. Despite there being a Republican in the White House and in both Congress and the Senate, it doesn't look like the Affordable Care Act is going to get repealed. But it is going to continue to get chipped away at. And there's a couple of things that you'll notice as you're kind of reading through sort of what's happening in Congress. The loss of the individual mandate, the loss of the uniform benefits in insurance products, sort of moving to higher deductible, sort of scaled back health coverage. And then lastly, the loss of the cost-sharing reductions. Now, this was federal dollars that went to payers that were participating in the individual exchange to offset the high deductibles, coinsurance, and copays. And without that, these products are much, it's harder for individuals to use them. It's more expensive. So the net result of all three of those things, though, is we're continuing to see double-digit exchange premium increases. So those people that are purchasing insurance through Cover Oregon, those costs are going up. And what we anticipate, and we're starting to see, is the ranks of the uninsured and the underinsured, meaning they have these scaled back plans that aren't very usable, are continuing to grow. Government-sponsored health insurance is growing. So there was a time when close to 65–70% of our population had some sort of employer-sponsored health insurance, but that's declining. It's, now it's less than 50%, and more than 40% of the U.S. population has some sort of government-supported health insurance, Medicaid, Medicare, or the government-funded components of the insurance exchange, Cover Oregon. And for those of you who work in the hospital, I mean, you'll recognize this because even within the hospital, it's more apparent because those people that are elderly or more ill that aren't commercially insured and are employed, those people are overrepresented in the hospital. So there's a couple of things to point out then, though, that businesses are increasingly pushing back on premium increases. Double-digit increases in the premiums that insurance is costing businesses is just unaffordable. And the high deductible plans, again, they curtail the use of those elective care items that sometimes would have ended up in the hospital. And then, as I mentioned, the individual exchange products, increasingly unaffordable to use. So all of that means that the commercial revenue coming into hospitals and health systems is declining. And that ability to cost shift losses that come from uninsured, Medicaid, or Medicare really is no longer viable. So it leads us to this last point around the market trends. The reimbursement increases in aggregate are not keeping pace with the climbing costs of delivering the care. And it's roughly twice, if you look at the reimbursement increases, they're running in aggregate from commercial payers and government payers at about 2% increase a year. And yet our costs and the rate of inflation is going up at about 4% a year. This is the conundrum that's facing most healthcare systems right now. And I would posit for you that where these lines intersect is where hospitals could start going out of business. And we aren't quite there yet, but we're close to that point. And so this is the fundamental problem that most healthcare administrators are sort of worried about. Our cost increase is going up, yet what we're getting from our payers is not going up fast enough to keep pace with that.
Can we ask questions along the way?
Absolutely.
So the thing that I have never really quite understood is that as we're trying to be more cost aware, you know, we're actually losing money for the hospitals. So how does that play out in the system as a whole?
Yeah. Perfect lead into really the next slide. So, because the question is, well, what, I know, that's awesome. It's like, how do you get out of this conundrum then? And so it goes back to this equation of the total cost of care. So we've been doing a lot of cost reduction, overhead reduction. That's working on unit costs. But the total cost of care is really the multiplied, the unit cost and utilization. So the other way to sustain a healthcare system might be to work on utilization. Now, is that the path forward? The answer to that question is yes, only though if you control a portion of the premium. Otherwise, by doing that cost reduction and utilization reduction work, that benefit accrues to the insurance companies.
But hospitals still get paid for that utilization.
they would if we own a portion of that premium dollar. But it also only works if you believe there's excess utilization. Now, it makes people nervous when we start talking about utilization reduction, because that could be thought of as just rationing or limiting access unless the enterprise is really focused on overall value. And if you define value as our outcomes and our experience divided by the cost, that might be a way to think about that. That value equation is really a lot of times thought of as sort of the definition of population health. So where does that leave us? You know, we've got lower reimbursements, catastrophic only health insurance, the lower paying government programs, the working uninsured, all these pressures, and you know, it sort of begs the question: does Providence have a strategy for those market forces? And the answer is, well, Providence always has a strategy. We're always thinking about this. Whether it was one ministry committed to excellence, or this is circa 2015, creating healthier communities together, we always have a colorful strategy here at Providence. And I love this one because it is colorful, and within that there's all sorts of things here around care management and medical homes and research and all the things that we need to have a great delivery system. But it's a complicated picture, and it was, I think, hard for people to get their arms around it. We've sort of refined our strategy a little bit, so now moving forward to sort of fall of 2016 at our Leadership Development Institute, we came out with this strategic intent statement. And we will excel at population health while providing personalized and compassionate care. Population health being defined as being accountable for outcomes, experience, and affordability of those folks who choose Providence. That's a little closer, a little more concise. Many of you will notice that looks very similar to sort of the triple aim, right? So again, this is now about 10 years old. Don Berwick and his colleagues at the IHI coined the term the triple aim, meaning if we could simultaneously improve the patient experience, our health outcomes, and affordability, that'd be the key. That's how you get out of this. So this is your first Back to the Future moment, because if you think back, there was another triangle in the 90s that some of the folks in the room might remember. So Dr. William Kissick, professor of medicine, University of Pennsylvania, a longtime health policy expert in this country, one of the original authors of the Medicare program back in the day when that started. He described the iron triangle, so a little different than the triple aim triangle. And what Dr. Kissick said is there are fixed rules in healthcare delivery, and that you could only improve two components of this triangle without sacrificing the third. So iron, rigid, and it kind of makes sense if you think about it. Like, we could improve the quality and access, but costs would go up. Or we could reduce the cost and improve quality, but we'd have to sacrifice access, and we couldn't deliver that care to as many people. So it does sort of make sense. So then it leaves us with this question: well, which is it? Can we do the triple aim triangle or the iron triangle? And I would posit that that those critics of the iron triangle would say, well, what gets you out of that fixed and rigid sort of description of healthcare economics is disruptive innovation. That's what changes the rules of the iron triangle. And you know, you can think about other industries where this has actually been the case. I love this picture of Bill Bixby, the original Incredible Hulk, not these new guys. And what you probably can't see down here, and I've circled in red in the bottom, was as this computer system came out, it would cost $2,999 for the Tandy 2000. And then, of course, the picture right next to it, a bunch of preschoolers using their iPads. It costs a tenth of that and have 10 times the memory and functionality that the Tandy 2000 had. So you kind of see this. Or tell me that somebody else's mom showed up to a soccer game looking like this and spent half your inheritance on the video camera and the phone and had to do weightlifting just to be able to carry it all around. And now, of course, your iPhone could do all those things. So I think there's precedent in other industries, but the question is in healthcare, what is that disruptive innovation? What is the transformation that can really change the rules of the iron triangle and allow us to simultaneously deliver access, quality, and affordability? So let's talk about those trends and the transformation that's necessary to succeed at population health. So I'd like to go through these over the next 15 or 20 minutes. Moving care to lower cost settings, eliminating unnecessary and low value care, eliminating errors and improving safety, segmenting the population, changing our incentives with capitation and salary, the development of narrow networks. I want to talk briefly around diversity and inclusion emphasis, and then we can talk some about hospital mergers and networks. So let's start with the moving care to lower cost settings of care. Not all of this has been intentional on the health system's part. Some of this is just responding to this era of consumerism. So folks want care when they want it, where they want it, how they want it. Blame Amazon Prime, but folks are not willing to wait 3 weeks to get in and see their doctor. And so we've increasingly been filling in this continuum of care with other sites of settings, many of which are actually lower cost settings. So, this spectrum here starts, at the end with the purple. It says e-visits or MyChart interactions with patients. There's now telehealth, like our Express Care virtual access for patients, retail or on-demand services, Zoom Care, Express Care for Providence, our traditional primary care, urgent care, ED, hospital care. It's a continuum. And if we're really going to solve some of the cost conundrum, the trick is getting the patient to the right setting for their acuity. This will take a lot of work, both on the healthcare system side, but also in educating the population about where they should go. We don't need folks with crushing substernal chest pain showing up at Express Care. But yet we also don't need the sore throat showing up in the ED. We may not even see them at Express Care. Maybe that's something we should be managing over the phone or by Express Care Virtual. But it's beyond sort of primary care services. This sort of shifting to other settings is also including ambulatory surgery centers, moving surgical procedures out of the hospital into community settings with lower overhead, more convenience for the patient, freestanding imaging centers, and then the ultimate might be down here at the bottom, the home-based care. What things do we do in the hospital today that we could manage at home with home health? Think osteomyelitis, cellulitis, some of those chronic conditions that we have historically kept in the hospital that actually, with the right infrastructure, we could be doing at home. Eliminating unnecessary and low-value care. So, back in his JAMA article in 2012, Don Berwick described that 20% of our healthcare expenditure is probably falls into this unnecessary and low value. Care that's not evidence-based, that might be redundant, or that might even include fraud and abuse and those sorts of things. That's $500 billion annually, if those numbers are correct. It's a huge dollar amount. And so work to sort of root out of our delivery systems unnecessary and low value care is something that is really going to be the work in front of you all, in front of clinicians over the next decade for sure. Choosing Wisely campaign, the ABIM campaign, I think is a great example of this work. We've now got 85 specialty societies that are involved with Choosing Wisely that have all said, here's low value care that we ought to root out of our subspecialties. And Providence has been very involved with this. We've had numerous projects that follow the Choose Wisely recommendations, whether that's reducing unnecessary CT scans in the emergency room, or the appropriate use of telemetry in our hospitals, or working on elective inductions before 39 weeks in pregnant women. We've had a variety of these initiatives where we have reduced utilization by eliminating this care. Down in the bottom there, the comprehensive care for joint replacement, and even though bundled payments from CMS may actually evolve or actually be sunsetted, that work that was done around our total joint bundles, around our pregnancy bundles, around PCI bundles, has been really fundamental work for sort of saying what's the right evidence-based care and what's unnecessary, and how do we root out the costs and really streamline those care. The bubble chart over here on the right represents Providence's value-oriented architecture. Just show of hands, how many people have heard about that yet? Okay, that's what I thought. So Steve and I are sort of monitoring this. We've got our programs working with some of our specialists. So this is a set of tools that Providence is using to help us get at this sort of what's the most appropriate care. So I'll try and explain what this bubble chart is, but it's basically the cost per case on one axis and the outcomes on the other. And so if you're up in this square, you've got lower cost and better outcomes. And each of those circles represents a provider. The size of the circle has to do with how many of a certain procedure those providers might do. We're now starting to collect and have the ability to analyze data on the care that happens in our hospital. And this has been the dream of things like why we have an electronic health record to actually quantify some of this. So it's fun to see it finally coming to fruition. But the idea that we could go out there and say, what are those things that really add value, or what are the things that might just add cost and not add value? And this example I think was around elective total knee arthroplasty, but it's which devices and the different costs of those devices, and do you use liposomal bupivacaine to numb up the incision site or just regular bupivacaine, and cost differential of tenfold those difference. Do you need IV Tylenol preoperatively versus a couple of Tylenol tablets to maximize pain? It's all those little teeny decisions that go into the care pathway, and which of those actually improve outcomes, which actually don't change the outcomes but might add to the cost. So it's looking for those people that have come across sort of the best practice, and then trying to sort out what are they doing, and then educating ourselves on the difference. This work has led to another project that some of us have been referring to as the Top 20 DRG Improvement Project. But basically we're trying to get at the question of, could we really cover our costs on Medicare rates by using some of this technology and some of this data analysis? So we're starting with a group of diagnoses that represent about 30% of the care or the procedure care in our hospitals. And again, what we've done here on this graph is those are the individual providers, the circles, again, individual docs, the cost. This is just utilization cost, not outcomes. The solid line is sort of the break even for meeting sort of the DRG reimbursement that we get from Medicare. And folks above that line, we're losing money each time they bring us one of those procedures, and folks below the line, we actually have a margin on that. But the idea is to sort out the variation and kind of get the variation to go down over time, and potentially over a few years get most of our providers of practicing care at a cost point that we can afford without sacrificing quality. Hard work, clinically involved work. Our administrators won't do this for us. This will be clinical leadership.
Could you give an example of one of those things and some of the specifics that you would try to work on, so to get from 2017 to 2019?
Yeah, I think, well, again, this specific example is looking at costs of total knee arthroplasty. And when we put together the joint bundle on that, I think that's maybe one of our better examples. It was things like the use of antibiotic-impregnated cement. Very expensive. Turns out the infection rate isn't any better if you're using just regular cement versus antibiotic-impregnated. So it's making a choice to do that. The local anesthetic, liposomal bupivacaine, much more expensive than regular bupivacaine. Using that, we're not changing the outcomes, but we could reduce the cost. But there's been a similar set of work that's gone on with our pregnancy care package and with the PCI package. There are clinical decision points along the way that we could choose that would be less expensive, that if we look at the data, we can figure out which ones don't influence the outcome. Patient safety. Patient safety never goes out of fashion, and so maybe it's wrong to think of this as one of those transformational things, but it's a journey we're on that I would put forward that we're not quite to our destination yet. We've done a lot of great work around our Caring Reliably campaign. But medical errors in our country still represent about $17 billion in the U.S. annually. Remember when I talked about unnecessary care, it was $500 billion, so it's right to keep those in proportion. There's less money to be saved in safety than there is in unnecessary care, but it's a big dollar amount. Again, the Institute of Medicine suggests that close to 200,000 people each year die from hospital-related medical error. It's an astounding number. Even within Providence in Oregon, 30 sentinel events last year, 30 catheter-associated urinary tract infections, 16 falls with injury. I mean, those are small numbers given the volume across our 8 hospitals, but even one bad outcome is too many. We need to continue to do this work. And so really the Caring Reliably campaign looked to that to be an area of emphasis in our facilities so that we can reduce hospital-acquired conditions. We're going to continue to measure serious safety events. We've had great success in our safety huddles. Many of you are aware we have an implementation of DATIX. It's a new event reporting system. So we've got a lot of terrific work at Providence going on to try and eliminate errors, and this will be a continued area of focus. Population health segmentation. Some of you have seen this slide before because I keep trotting it out to make this point that we can't treat all of the patients that we're accountable for in the same way. So if you think about this population health triangle, it's like squeezing all of your patients that we're accountable for into a triangle. And you could divide it up into 3 categories: low risk, rising risk, and high risk. So low risk are the folks that you all don't see very often. Those are the relatively healthy or well people. We need to be doing things to keep them well. And maybe we don't need to care for them when they have a minor acute problem in the more expensive medical home. Could we be managing them on demand or telephonically? Wellness programs in particular, though, to make sure that we're emphasizing sort of exercise and appropriate diet and not smoking and avoiding substance use problems. Those are the things we need to be doing and focusing on for those well folks so that we can keep them from setting up into the rising risk. Rising risk might be those folks that have 1 or 2 chronic diseases, hypertension or diabetes or COPD. And those people need regular medical care. They need the infrastructure of the medical home. They need to be managed on a disease management software platform that makes sure that they're meeting all their milestones so that we can keep them from ascending into the smallest portion of the triangle, so representing the smallest number of individuals, but certainly the highest cost of our delivery system, and that's at the top of the triangle. And you all would recognize these folks. These are the folks with long problem lists, long medication lists, who are in and out of the hospital frequently. And while the medical home certainly has a role in managing those patients, many times they need extra help, and we need wraparound services to really keep them from being in the hospital and to keep them well. So it's case management, it's outreach, navigator programs, those sorts of things. You know, I think one of our better examples recently has been the Elder at Home program. The Elder at Home program is a program that we put together to manage a subset of the Medicare Advantage population that we're accountable for. So the example I use, you know, in the Portland market, we have about 30,000 Medicare Advantage patients that PMG is taking care of, the Providence Medical Group. And of those, about 10%, about 3,000 are really sick. You might be thinking of them as homebound. An example would be a 92-year-old with a creatinine of 2.5 and spinal stenosis and atrial fibrillation and heart failure, and she's in and out of the hospital a lot. And what the Elder at Home program does is it gives them access to a visiting nurse 24/7 within an hour of a phone call to be out in the home. Because what happened before the Elder at Home program is Mrs. Jones with those problems would start getting a little short of breath. And she'd say, well, it's a hassle. I have to call medical transport to get into the doctor's office. Maybe tomorrow will be a better day. I'll wait. Tomorrow comes. Now I'm really short of breath. I can't wait for an appointment in the afternoon. I just call 911. I show up in the ER. On a good day, Mrs. Jones is admitted to the hospital. So certainly on this day, with rouse a quarter of the way up, she gets admitted. Enter Elder at Home. Now we've got a visiting nurse that goes out, listens to her lungs, puts an oximeter on her finger, calls the geriatrician, says, I think she's back in heart failure. Let's double her Lasix dose. I'll be back out to see her in another 6 hours. Let's make sure she's diuresing, and I'll check on her. Patient very happy, very satisfied. I didn't have to go to the hospital. I'm getting the care I needed, and far less expensive for the health system. So that's one example of these wraparound services for these high-risk individuals. We'll need to do more of that going forward. You know, when you think about population segmentation, I think it's key to understand sort of those vulnerable populations. And we've really talked about that as seniors, the Elder at Home example, but also behavioral health patients and children with either really complex illness or high ACE scores that have been subjected to trauma earlier. We know that those people become high-utilizing Medicaid members down the road. So we need interventions with all three of those groups to really be successful. All right, this is the next Back to the Future moment, because many of you sort of remember the years of capitation. But we know that we need to decrease utilization. That's part of affordability. And you can do that on the health plan side with benefit design, higher deductibles and copays, but those are pretty unpopular. So those only take us so far. So then we start, you know, well, can we influence this with provider incentives? Because today, on an RVU or production model, you know, doctors make more when they do more. We don't necessarily have incentives around outcomes. We have incentives around volume. Capitation and salary. So when you're paying medical groups by a per member per month rather than by encounter, it promotes a variety of non-traditional care. RN visits instead of having to see a physician, group visits, telephonic and virtual platforms. It provides an incentive for docs to do multidisciplinary case conference, even if the patient isn't there face-to-face. It provides incentive to move care to lower cost settings. So I think this is part of our future, and truth be told, we are doing this in the medical group. With Providence Health Plan now, we're getting paid by capitation rather than fee-for-service in PMG this year. That's new for us. We hadn't done that since the 90s. And we moved most of our primary care doctors this year into a salary model. Now that salary model is you know, it's predicted each year by a variety of sort of outcomes, quality, utilization, and still there is a volume component of that. But again, it's getting people to think a little bit differently. Yeah.
So one of the stressors back in the 90s was that primary care worked under capitation and our specialist colleagues were fee-for-service.
Yeah.
Is that going to be different this time?
I mean, it's like you've been reading my slides. I'm sorry, Claudia. I'm just going to take this off and hand it over now. Yeah, right. We've been here before, right? And why did it not work? And, you know, I say, why did HMO fail except for Kaiser? Because obviously Kaiser is thriving. They are doing well. Yeah, sorry for the pun. But the gatekeeper model that we used in the 90s, it set up this conflict between specialists and primary care. So I think, you know, part of the answer to that question is doing capitation, but not sort of putting it all in the back of primary care doctors and putting them in that gatekeeper role. So could we do specialty capitation? Could we have salaries across both primary care and specialty? I think those are sort of the questions before us as we do this. But there are other reasons why the HMOs of the 90s and capitation during that era didn't work as well. We didn't have good EMR connectivity at that point. So we didn't have good visibility of what was happening in the outpatient versus inpatient. There was redundancy, and we'd repeat tests and labs. And Our provider groups at that point, really, they lacked actuarial experience and negotiating resources, so some of them got in way over their head with taking risk that they had no business taking. A small panel size, taking risk, and then a couple of outlier high utilizing cases, and they lost a lot of money. I mean, that's why we saw practices go out of business during that time. Patients also didn't have a role in this. So I think this is one of the other things we need to think about as we step back into this role is how do we have patients have some skin in this game financially too, so they have some reward as well when we reduce utilization. And then I don't think we had good transparency in our outcomes. So patients were making decisions on which HMO they might sign up with or which primary care provider based mostly on patient experience and not much on outcome. And then we lacked some of the utilization and care management analytic tools that we have today. So I think it could be different this time around. We tend to talk about this as clinically integrated networks, narrow networks of providers who are sort of like-minded and want to manage both the total cost of care and deliver good outcomes and a good experience, integrated across either an EMR or some sort of HIE platform. Who are willing to sort of produce a regular experience for patients and that are adequately connected to financial reserves. So I think that is the path forward. But I worry a little bit about the clinically integrated network because it's putting a lot of pressure on some of our private practice colleagues and more so I think on primary care providers than our specialty care providers. But I mean, you just go through the list. You know, MACRA is going to reduce at least the Medicare reimbursements. Many of these providers now are excluded from narrow networks because they don't have all the infrastructure of medical home and team-based care, so they don't have access to the number of patients that they used to. It used to be that primary care doctors could, you know, manage patients at Legacy and at Providence, and that's harder to do, different EMRs, different policies. Many of our primary care doctors out there don't have sort of the contracting and purchasing clout that you would in a larger group. So let alone the issues around sort of docs looking for the safe harbor of a regular paycheck and not wanting to run a business. So it's a lot of pressure on primary care, and I think we're going to see more primary care doctors either group up into larger aggregates. I mean, I think some of the larger clinics, Northwest Primary Care, the Portland Clinic are probably going to do pretty well, but I worry about the small independent docs. And so, yeah, some of them are actually looking to be hired. Am I answering this question okay, Jim? I'm looking at Dr. Beamer over there. He and I have questions about this a lot because I think it's good. I mean, Providence has always described itself as an integrated but open health system where we have open arms to our private practice colleagues. And we have to work really hard to try and make it a viable setting for them. I think we're going to need this emphasis on diversity and inclusion. In 1980, only 8% of Oregonians would be described as ethnic or racial minorities. By 2015, it was 24%, quadruple that number over that period of time. They say that by 2020, actually folks who are in ethnic minority groups will actually be the majority of kids entering our schools. We've sometimes called this a browning of America, or sometimes we talk about the graying and the browning of America. We're managing an older population, but a more diverse population as well. And in particular, in a place like Portland, it's not just the color of your skin, it's culturally. We see a lot of folks that are immigrants to our country that have different cultural expectations around their health care, and we have to be smart about there. So there is this sort of a diversity mandate, I think is what I said it, where we have to be culturally competent in how we deliver care. We have to embrace workforce diversity. We need to look like the population we're serving to better appeal to that market. And Providence is responding in this area, so I don't know if it's all that transparent to everybody, but we have talent acquisition strategies to really acquire and maintain a more diverse workforce. We have diversity and cultural competency training that's happening throughout our organizations. But if we're going to be successful in the future, this is part of our transformation. So we'll talk just a little bit about hospital mergers. This could be a back to the future moment too, because some of you have lived through sort of these eras of hospital mergers. I'll describe them. So, I think I described that first era as kind of these standalone hospitals. These are the hospitals that weren't doing well financially, looking for the safe harbor of a system, and doing that mostly to get capital, local coordination into specialty practices. So this is sort of the late 80s, 90s. This is, when Willamette Falls joined Providence, when Mount Hood and Meridian Park joined Legacy, those sorts of times. Then we entered the second era of mergers and hospital affiliations. And I would characterize this as sort of the strong joining with the strong, if you will. So this is, Swedish and Providence coming together, or Cadillac with Providence, or Hoag with St. Joe's. And these affiliations were done for slightly different reasons. One is to sort of consolidate a balance sheet for more financial security, so you could weather a market change in one geography and not have it be unduly influencing the financial security. But also to do things like make IT investments at scale. When Providence purchased Epic, we purchased it across 5 states at that point, across numerous hospitals, and we got deeply discounted rates for that. But also for drug acquisition, device acquisition prices. So there are reasons to do that can bring value to the community. This last era, though, this combining regional and national networks, there's something new that's out there in the market now. And first you were seeing sort of insurance companies attempt to sort of merge. The Aetna and Humana and Cigna and United, and the FTC was putting the brakes on some of that because it was creating too big of monopolies. But now the insurers are also sort of merging with some provider groups. So Optum, which is an arm of United, combining with DaVita, MedExpress, Surgical Care Associates, Aetna with the CVS Minute clinics. And then to counteract that, you're seeing large national networks of hospitals developing. The merger of CHI and Dignity, or in Wisconsin, Advocate and Aurora. There were some conversations about whether Providence might merge with Ascension, and I think we've pulled back from that, and we've decided that wouldn't bring value, and it would just actually make us less nimble. But I describe this last phase as really not transformational. It's more protectionistic. The insurers are trying to get big so that they can put pressure on hospital systems to take a lower reimbursement rate. And the hospital systems are trying to get big to tell the insurers, you can't cut us out of your network. We're too big. You need us for network adequacy. It's not really bringing value to the communities, but it's certainly this phenomena that we're seeing. I firmly believe that Providence is well positioned really around our concepts of an integrated delivery system. So if you define an integrated delivery system as sort of owning the entire continuum, you have a health plan, you have a hospital, you have a medical group, you have specialists, you have home health, that whole continuum. And especially because we're connected to the insurance arm, we can be connected to that premium dollar. And that allows us, as we do some of this utilization reduction and efficiency, to actually harvest that financial savings. But that single bottom line also helps us because we can put together things differently. Again, the Elder at Home program is a great example of that. We've built that out of home services, and home services loses money on that, and they run a deficit of that, but we gain it back on the health plan side. So when we have a single bottom line, we can do the right things for patients and financially still be stable. The seamless care pathways, there's lots of reasons why working together as an integrated delivery system, I think, is the future for us. So I'm going to transition just a little bit here. I've only got a little bit of time, but I wanted to talk about some of our system office leaders because you may see some of these slides out and about. Amy Compton Phillips, she's our Chief clinical officer at our system level. And Amy uses this slide from time to time to talk about sort of the right strategy for healthcare. And you'll notice those of you who are fans of the Institute of Medicine will say, this looks a lot like STEEP. But it's sort of this platform of starting with safe care, building it to effective evidence-based care, adding compassion and experience, seamless, personalized, high value, and she describes this as our path forward. It's very clinical orientation and thinking about how you deliver good care to a population. I think it resonates with most of the clinicians when she rolls this out. I'm not sure that it solves some of the economic concerns that we've talked about earlier, but it is a nice platform to talk about what we're trying to achieve. Some of you may have met Dr. Rhonda Meadows. She's our Chief Population Health Officer at the system office level. And Rhonda also has accountability for the health plan, reports up to her. She describes our strategy in these three big buckets: improving health, providing value, and build healthier communities. Now, the improving health in the green there, a lot of that is the same stuff that was on Amy's slide. It's clinical quality, it's experience, it's care coordination. The new things are probably found in those two other buckets, so the providing value. You know, there we've got things like payment models that are different, care management, contracting. So she's got this other lens about where are we going with healthcare that brings value. And then lastly, this blue area I think is interesting as well, because now she's talking about really moving upstream and building healthier communities. You'll see some of that is getting out into the communities and thinking about social determinants of health, housing, transportation, food security. If we can do that for populations that we're accountable for, that can reduce the medical spend down the road. So that, again, a little different set of strategies from Dr. Meadows' perspective. And then lastly, some of you will see this slide here too. The picture there is Venkat Bamyapati. He's our new system CFO. He's been with us just for about 6 months. Came to us from Microsoft. Has no background in healthcare, other than the healthcare he might have received as an individual. And so, you know, came to us from the software industry. You can see we've got Healthcare 1.0, Healthcare 1.5, Health 2.0, sort of like Windows 7. Anyway, it's just, you know, it's another release. But I think the picture, if I can try and explain it a little bit, back at 1.0, this is historically where a lot of our hospitals and health systems started. That you build a health system around the hospital. And you have physicians that come into the hospital and specialists that come into the hospital, and you develop ancillaries and post-acute care, but it's all really to feed the hospital, and it's a business about and for the hospital. Graduate that to Healthcare 1.5, and now we've become patient-centered. And now all those services are really to bring more value to the patient. And so you develop an integrated delivery system. I would say very much this is where Providence Health and Services in Oregon is really developing this integrated delivery system where we have all those components: the providers, the hospital, the lab, the insurance company, post-acute care, all focused on doing the right thing for the patient. So then what's this Health 2.0? It's now got this other ring around it. And I think if you talked with Venkat, he would say, you know, our margins are such that Health 1.5 is not sustainable, and we're going to need to do something else. And so this outer ring are other businesses that are sort of quasi-health related that might generate a revenue that, when combined with the healthcare enterprise, keeps us sustainable. So could we develop a telehealth platform that we not only use in Oregon, but could we sell those services to other healthcare systems across the country? Could our retail services that we're doing, could we parlay that into some sort of partnership or franchise across the country? Could we, with some of our data assets, create database and create new knowledge that we're selling, or we're working as a consultant to other healthcare delivery systems? So you can kind of see they're all sort of health related, but it's not really about the care we're providing, it's selling services. Venkat refers to this as alternative revenue streams. and maybe that's going to be necessary. I'm not sure that it's what we in our Oregon region focus on all that much. I mean, I'm glad there's folks at the system office that are thinking about generating new revenue that they can funnel into healthcare, because I'm worried about the healthcare economics. But I think that feels like sort of a system set of work, not necessarily ours.
And mental health is going to make money?
Well, I don't think so. Although mental health is, again, think not necessarily at clinical services, but could we develop a foundation? Could that foundation partnership with other industries, with schools and other things that we're selling those kind of services outside of healthcare? I don't know. Maybe it's a stretch.
Doug?
Yeah.
If we look at 1.5, which is embedded in 2,
Yes.
it seems to me that we are underutilizing the potential for both economic savings and healthcare delivery within what we already have in 1.5.
Mm-hmm.
The outer green rim of 2, I think I know the names of some of the people who influenced some of those little ingots, and I agree with you that it's pie in the sky. However, we have not fully exploited what we already can do.
Mm-hmm.
It would be silly and irresponsible to think that any source of income that we now have is going to expand.
Mm-hmm.
We hate to say that we have to save our way out of a crisis, but that's what we have to do. I think that everybody who sits in this room, everybody who cares about what they do in medicine, doesn't want to surrender and always fears the surrendering of quality of care being imposed upon us because of less resources.
Mm-hmm.
If we can, and you and I talked about this just briefly before you started, if we can increase the amount of healthcare patient interaction that's meaningful,
Mm-hmm.
yet reduce the time commitment of the most valuable shrinking asset we have, namely physicians and nurses, relative to the population, it seems to me that's where we should be going. We have medical records, we have digital health systems that we're not really utilizing to interact with
Mm-hmm.
patients. The problem with telehealth is it takes a human being on the other end of the TV screen with a set of earphones on, so it doesn't save any time.
Nope.
So I think we should look much more seriously and much more deeply at the assets we already have in a number of different areas. Say, okay, how can we deliver the goods at a lower cost, maintain the quality, and then if you want to market that, hey, I've got a platform that you folks in New England might want to use, fine, go sell that.
Yeah. Yeah, I'm not sure if everybody could hear Dr. Cohen's comments. But I agree with you 100%. And basically what he is saying, I think, is that we shouldn't be so quick to give up on 1.5. We have work to do there. You know, I sometimes, and especially outside of the Oregon region, I sometimes think that we've given up on being able to deliver value by thinking smarter and doing care differently and actually bringing that value. Maybe we can get by with that. But if we're not coordinated, if we're not using digital technology, if we're not using alternative care settings, we are going to continue to lose money, and then you're going to need alternative revenue streams. But I still think there is a bunch of work at 1.5 to work smarter and better, to have everybody working at the top of license. I think that's the work in front of us as clinicians. So I agree with you. This is, I think, my last slide. Again, and we're about out of time. We'll have a little bit of time for questions. But I am optimistic around where Providence, certainly in the Oregon region, is going. And I'm optimistic for a couple of reasons. One, I think we've attracted folks like yourself who have a strong sense of calling, who want to practice the right kind of care and can do it compassionately, that have a real commitment to our mission. And many times that means being willing to think about doing things differently, to evolve and transform our delivery model to maintain that mission. And I'm also optimistic because our health system really, it puts a big emphasis and value on physician leadership and teamwork and I appreciate so much folks like we have in this room thinking about this with me. So that was my last slide. So thank you. Shelley.
This might just be saying what Dr. Cohen said another way, but stewardship is still up as a poster, but it was removed, and the green ring came. And as I do the sepsis work, there's a lot of question about, should I go up to Seattle and start working on research? Like, could we build a product that we're going to sell? And yet it doesn't feel to me like that's what the Sisters of Providence had in mind. So I'm just saying it one more time, and I'm curious your experience with the new mission. Did taking the word stewardship away bother anyone outside of Oregon?
Outside of William Olson, I think it did. William's our Chief Financial Officer in the Oregon region. I think folks would actually suggest that stewardship isn't gone. It's not held up as a core value. It certainly is embedded in integrity, which is one of the new core values, that doing the right thing for the right reasons, being mindful of the resources that we've been given is part of integrity. So I still think it's there. But maybe more importantly, we have to be accountable for the care that we're delivering here, and we have to think about doing the right thing. And, again, back to that slide, the Don Berwick slide about doing evidence-based care that's the appropriate care, really important. There is still an awful lot of waste, and we're accountable for it. It's our keystroke that spends those dollars for the most part.
You brought out the idea that there's some competition, there's a zero-sum game to some degree in the triple aim, and you've also made a strong case that integration is the way to solve some of that. Mm-hmm. Is that an argument for a single national health program?
I have to be very careful how I answer this. I've been misquoted on single payer on numerous occasions. And when you think about a national health program, there's a lot of different types of plans in there across the world. Without a doubt, we have waste in our system goes to administrative overhead related to have multiple different payers. But we need to be careful with that as well, because many of the single payer systems are sort of just a fee-for-service model. Now, if it's Medicare for all and you can have a Medicare Advantage where you have assignment and you can work in sort of an integrated delivery system, then I think you can bring that value. So I don't know if we'll hit there or not. I think things would have to get a lot worse before they get better for us to have the political will to move in that direction. I certainly don't see that happening in this administration or maybe even the next. So I think it's out there a ways. So I'm dancing around this a little bit. I still think that our focus on the integrated delivery model and rooting out unnecessary care is going to serve us well no matter what kind of model we end up living in. Steve, and then we'll go up there.
I won't have to dance around it. I'll just, it was Winston Churchill who said, you can always count on the United States to do the right thing after it's exhausted every other possibility.
There we go.
Maybe that's the answer to that question. I think, to Stan's point, I worry a little bit that green outer ring ends up being a distraction away from some of this. I mean, we're so seduced by these technological things that we fail to recognize where the real work of our core enterprise lies. But the question I had for you is around this concept of narrow networks, and I understand it's about controlling the premium and controlling costs. But as more and more patients can access data about outcomes, they can see where the best work is done, and they will be telling us, I appreciate that you have a nice narrow network here that you'd like me to stay within, but they do it much better over here. I want to go there, and why should I not be able to go there? I'm paying you money to ensure my health, and my health will be better served if I go outside of this network. What do we say to those patients?
I don't know. We've had a variety of cost transparency and quality tools that have been available actually for 5-8 years now, and patients aren't accessing those to the degree that I would have thought ahead of time. So I'm not I'm not sure that patients are going to do what you say. Or
Maybe they don't care.
well, or they don't ask the right question. They ask their brother-in-law, who's the guy that did your knee that you really liked, rather than actually having verifiable outcomes data to sort of point to. I think, though, the onus on us will be to understand that performance nationally and understand what the benchmark is and make sure that we've attracted high-caliber folks who can practice at that quality level so that we can really say, well, actually, here's our providers, and they have as good or better outcomes. You know, it's funny because people oftentimes say, well, I'm gonna go to the Mayo Clinic, and yet we've got better MS doctors here than they do at the Mayo Clinic. And it's, so, some of this is telling our own story. And
But that's reputation, that's not data.
right,
So,
yeah.
The problem with data is what you decide to talk about and how you talk about it. And someone might say, we are the best hospital in the United States, and yet the criteria that are used to come to that conclusion have relatively little to do with the quality of healthcare.
they all say that.
So you have to be very, very
Yeah.
careful when you start, right?
Yeah. Let's see, we had a couple of questions.
My question was a quick follow-up to Dr. Schaefer's question, which is, maybe we can't have a single payer system just yet. However, I'm wondering if there are organizational sort of savings or efficiencies that can be found in integrating the PHP and PHS a little bit better.
Yeah.
As a user and a consumer, both of PHS and PHP services, I can see that, the reimbursement or the claim process is still quite cumbersome. And at least locally, could we find a slightly more efficient way of doing it, more similar to what Kaiser's doing?
Yeah. Yeah, I don't know if any of you all have worked in Kaiser, but this question is like a non-starter for them. They don't really even think about, what do you mean different insurers, different payers? Mike Cotton, who's our executive over the health plan, would describe for you something short of single payer, where you could use the infrastructure of PHP, carve it out as a separate organization, Providence Plan Partners, use that as an MSO. That's the entry point from other payers to get access to our delivery system, our providers and our hospitals, United, Regents, all coming through them, so that then on the back end for the providers, it's all seamless. We have one set of referral guidelines, one formulary. I don't have to think about multiple ones because all those patients are funneled through Providence Plan Partners. Now, I don't know if we'll be able to move the other payers to that, but I think that's one avenue where you could get at exactly what you're describing, is we haven't gone to a single payer, but we've aggregated under Providence Plan Partners to create a single venue that all the other various payers come in. I think that's a very interesting idea, and we definitely are going to explore that over the next few years to see if that could actually happen. Yes?
So, in the 1990s, your slide said that these patients did not have skin in the game. So I was looking for the patients who have skin in the game in the future, and I missed it.
Yeah. Right, you'd like to think, well, the skin in the game is I care about my own health, and so I want to go to the doctors who are providing the best outcomes and experience because I care about my health. But all of us have experiences where patients don't necessarily behave in that fashion. I think when there's cost transparency and it affects the premium amount that the patient might pay, and they can get lower premiums based on their health status, that's a way to sort of get some skin in the game. And there are various employer groups, self-insured groups who are already doing that sort of thing, charging patients less in the healthcare costs for their insurance if they're non-smokers or if they join a gym or if they do those things. So I think it's, there's little bits of it out there, but I think we need to be creative about how we could get our patients more involved than that. We don't have a good answer yet, really. I'm over time, so.
Very respectful. We're past 9, but thanks for the interest and thank you for being here.
Thank you, everybody.